My name is Natalia Rachmanina, and I'm in charge of the HIV services at Children's National. And I'd like to thank you for coming, and I'd like to thank those who are attending by Webex. And I'd like to thank the organizers of the Grand Rounds for giving us this time slot. And just want to start by saying we have a very special Grand Rounds today on December 1st, World pays tribute to the World AIDS Day. And this is just every year we get the Grand Rounds dedicated to the HIV/AIDS epidemic globally in the world. We have made some amazing strides in epidemic, but there's still a lot of issues to handle. And I just want to say we're absolutely thrilled to have a talk today that focuses on the prospects of cure and really looking realistic outlook on it. But before we start and before I introduce the very distinguished and very honorable speaker we have today, and very lucky to have her, what I'd like to do first is to pay a tribute to those people in this hospital who serve HIV patients. We have one of the oldest pediatric HIV programs in the country, and unfortunately, even today, have one of the largest pediatric adolescent HIV program in the country. Our numbers are up there with large metropolitan areas and even higher compared to the areas, hubs of epidemics such as New York, Florida, and other locations. This institution has been serving children and adolescents for over 35 years, close to 35, over 35 years. And we are very committed as an institution to continue doing this service. Before I start, I would like to ask all the members of HIV services stand up, just that you know how large the team is, please, people. So, and these are the people who work with our people populations in the clinic. So, thank you to every one of us. And we want to honor our patients and our families. A couple of families haven't expressed interest to attend, and some of them might be on WebEx. And those, if we have families and our clients that might be attending on WebEx, thank you and welcome. And if anything is unclear lecture-wise in terms of science, we're all happy to discuss with you further any information today. With that, let me go ahead and start by introducing our speaker today. We're very lucky to have Dr. Deborah Prasad to present today. Dr. Prasad is a professor of pediatrics, molecular microbiology and immunology, and international health at Johns Hopkins University School of Medicine and Johns Hopkins Bloomberg School of Public Health in Baltimore, Maryland, just very close to us. She's very well renowned for her work on the HIV latency, specifically on the sleeping HIV status in the children and adolescents, and trying to detect the mechanism by which the infection could be potentially fully eradicated. Most importantly, she was the one who led, and her expertise and research led to the description of the first case of the HIV remission in a pediatric patient in the States in 2013. Some of you might recall so-called Mississippi baby. And as a result of that research and that particular case, the whole line of new HIV cure research and whole new agenda in pediatrics have been generated. Not for nothing, in 2013, she, along with two colleagues who described this case, Dr. Hannah Gay and Catherine Luzuriaga, were named in Times Magazine as 100 most influential people of the year. And also individually, Dr. Prasad has been named by the Nature magazine as one of the 10 people who mattered in 2013. But her contributions go well beyond the 2013. She's also a recipient of multiple awards, including Doris Duke Clinician Scientist Developmental Award and Elizabeth Glazier Scientist Award. She's published many manuscripts and continues to do one of the most robust research in the area of HIV remission and cure. And she also serves as a scientific chair for HIV Cure Scientific Committee of the NIH Sponsored Impact or Infant Maternal International Maternal Pediatric and Adolescent Clinical Trials Network. She just came from one of the cure-related meetings in Europe on that matter. And in addition to being absolutely remarkable and stellar scientist, she's just extremely warm individual and great mentor to many young professionals and a mother of three, which I don't know how many could do. So we're absolutely thrilled to have you here, and we're absolutely thrilled to have a glance at some amazing research you are doing, and thank you very much for finding time and coming here.
Good morning. Can you hear me? Clearly? Great. Thank you, Natalia, for that really excellent introduction. I feel I should just sit down and stop at this point. But it's really a great pleasure to be here. And Stella asked me on the way over, have I ever been to BC Children's? And actually recall I ranked this #1 for pediatric residency training, but was not accepted. I did my residency training at Columbia Presbyterian Babies Hospital in New York City. And actually it's where I met my husband, and I was actually very fortunate. It's when the HIV epidemic started, so you'll know how old I am. So I trained in 1981 at Bellevue Hospital, and the wards were filled with, for my medical school training, the wards were filled with patients with AIDS. So personally, on World AIDS Day, it's really very, very gratifying to be able to talk about this topic of HIV cure research and the potential capacity to transform HIV into a curative or at least an illness that we can put into remission where patients can go off antiretroviral treatment. So World AIDS Day, this is the 30th anniversary of World AIDS Day. It's really to commemorate those who have passed from this illness. And I'll get started on my talk. So I have no financial disclosures, and as this is a CME accredited event, the learning objectives are stated here to discuss HIV reservoirs as barriers to cure, describe the different biomarkers used to measure HIV reservoirs and persistence, define the terms HIV remission and cure, which is really critical as we move forward. We've learned from the case of the Mississippi baby that using the word functional cure, which is how we describe that case, was actually very misleading for those living with HIV. And so the field has come around to really be more specific in what the goals are with respect to remission and cure, and I'll define those during the talk. And then to be able to identify therapeutic strategies aimed specifically towards HIV remission and cure. And so, as Natalia said, really on the right-hand side, we have to start World AIDS Day and talk on World AIDS Day with the numbers. And what you see on the right, more people are living with HIV. 36.9 million people are living with HIV. 1.8 million of those are children less than 15 years of age. But what you see on the left, so the increase in numbers is actually due to increase in survival. What you see on the left in red are the number of new infections. And so in terms of new infections, there are 1.8 million new infections in 2017. And in gray are the number of deaths, so 940,000 deaths. With respect to new infections in pediatrics, there's still, despite progress in knowing how to prevent mother-to-child transmission, 180,000 new infections in infants worldwide. So these are the numbers of the state of the epidemic. About 70 million people since the start of this epidemic have been infected with the virus. So UNAIDS has this 2030 mission to end the AIDS epidemic, and as you can see, their current assessment based on the numbers that I just presented to you is that we have miles to go in order to close the gaps in terms of decreasing new infections worldwide. And so on the bright side, so the topic here is really hype or hope, and hope or hype, depending on which side of the glass you want to look at it. And I think as I present each piece of information, you can think about whether this is hope or hype. And I think the main hope we have here is that we've made tremendous progress for treatment of HIV. We now know how to control HIV from replicating within an infected person, starting from the newborn to 80-year-olds. Yes, 80-year-olds do get infected with HIV. People living with HIV can live to age 80 now. We have in our toolbox, at least at last recall, this list is growing because there are now many fixed-dose combinations, 27 FDA-approved antiretroviral drugs for the treatment of HIV infection. These are used in combination, 3 or more drugs in combination from 6 different classes that target different parts of the virus life cycle. And so what we've seen with combination antiretroviral treatment since it was started in 1996, and I'll go through some of those seminal studies showing the effects or efficacy of combination antiretroviral treatment in suppressing virus replication in HIV-infected adults, starting therapy from 2008 onwards with these newer combinations. The life expectancy is actually reached near normal. So these are the data in adults recently published in 2017. I think it was a 88,000 person study. And what you see in the bottom left in purple and green are combined 3-year survival. if you by age, by year. So 2008 to 2010 is where you see this dramatic upswing in survival, up to 68 years in an HIV-infected person starting therapy about 20 years of age. But on the upper right, there's a high mortality in the first year starting antiretroviral treatment, and then disease progression stabilizes. So in the top two lines, the red and the blue, or if you then look at individuals surviving to the second and third year. And that's where the life expectancy approaches that of a normal individual, around 78 or 74 years for men. So significant progress has been made, and we should really celebrate this progress, and there's tremendous efforts being made to make antiretroviral treatment, combination antiretroviral treatment available worldwide. Now, the story is different. So we're pediatricians here, and so you'll see a lot of this talk. While it's a comprehensive overview of the state of clinical trials in cure research in adults and children, there is some skewing towards a pediatric focus or lens because of my area of interest. But the story is very different for perinatally infected youth. This is a study on Impact P1074, looking at youth in the U.S. 87% of these kids were perinatally infected, so there were 13% that were infected non-perinatally through high-risk behaviors. And what you see here, I mean, kids are living with HIV. I mean, the median age of death here was about 24 years of age. But what's important is distinct from adult populations is a standardized mortality ratio is almost 32-fold higher in an HIV-infected child compared with the general use population. So when we try to make an argument in terms of is there a need for cure, is there a need to try to really stop this virus from rebounding when therapy is stopped, I think the pediatric scenario is where it's really very critical because these kids face a lifetime of antiretroviral treatment, as I'll go into later in the talk. The existence of viral reservoirs preclude eradication of the virus from all infected cells, and therefore ongoing antiretroviral treatment, a lifetime of treatment is needed to contain virus replication. As most of you know, caring for pediatric and adolescent patients, adherence is very difficult. It's life-altering to take medications daily to control virus from replicating. We're in an era now of very early antiretroviral treatment, so infants being born with HIV are now being started antiretroviral therapy within the first 48 hours to the first week of life. So consider 25 to 30 years of continuous antiretroviral treatment. It's just not a feasible option long term. So really to go back to the science of HIV therapeutics, and I think these were really seminal studies done in the 90s by David Ho and Alan Pearson, really defining the dynamics of HIV replication. And what we know is the target cell for HIV is really activated CD4 positive T cells. Within these cells, the virus is very cytopathic, high virus production of free virions. The half-life of these cells are about 1.5 days. So most of these cells, this is what their current antiretroviral drugs target. They target active virus replication in activated CD4 positive T cells that produce 99% of the free virus that's measured in the peripheral blood of an infected individual. But what was realized is less than 1% of cells, during the course of acute HIV infection, a reservoir for HIV is established, a latent reservoir, and as Natalia mentioned, it's where the virus remains quiescent or hidden or sleepy. It doesn't express itself. These cells are memory CD4 T cells. They're designed to live for your lifetime to provide immunologic memory. So the virus is capitalized on a cell type that has mechanisms for self-renewing itself or living for a very long time, meaning your lifetime. So this is really the major barrier to HIV infection. So while we can control free virus production and infection in susceptible target cells, these latent infected cells are not targeted by the multiple drugs I showed you before. So what we understand through these studies is that there are different populations of cells harboring HIV that respond differently to antiretroviral drugs. So our current cure therapeutics are focused primarily on eradicating HIV that persists in resting memory CD4 T cells. That's not to say there are not additional reservoirs for HIV. It's just specifically there's some concerns that the brain could be an anatomic reservoir for HIV. the brain has been very difficult to sample to really characterize the reservoir aspect of infection in the brain. But obviously, the latently infected pool is what's been the most studied and the most challenging with respect to eradication. So what we hope for and is that in an individual on antiretroviral treatment, and we've had kids in the U.S. started on antiretroviral treatment at 2 to 3 months of age who maintain suppression, continuous suppression to undetectable viral loads up to 20 years. And I'll show you in those kids who we refer to as early treated adolescents or early treated children have a unique biomarker profile of persistence that's an ideal landscape for HIV curative treatments and measures. But what you see on this slide is despite clearance of free plasma virus, there's still this stable pool of infected cells, resting memory CD4 T cells, that harbor intact proviral genomes that can be activated, reactivated at any point to produce infectious virus. And therefore, we need to continue treatment. If treatment is stopped, there's prompt rebound in Viremia. Now, these are the seminal studies showing exactly the nature of HIV persistence and the recalcitrancy of this virus. So these were studies done in 1999 by Davy et al., really 3 years after ART was initiated. And what they showed is that in treating patients for up to 2.2 years, if you stop antiretroviral treatment, the mean rebound time is about 2 weeks or 14 days. And keep this number in mind because this is really how the Berlin patient, who I'll discuss later, the only patient who's been cured of HIV was identified because off antiretroviral treatment, there was no rebound of virus in the plasma in that patient at 20 months post-transplantation. And now he's 10 years out without rebound viremia. And similarly in Mississippi baby, we knew in children going off treatment, the same kinetics of rebound, really about 2 to 4 weeks, this prompt rebound in plasma virus. And in that child who presented 5 months off antiretroviral treatment without rebound viremia, we realized there was a different situation in that case. And so the search to figure out why that child did not have rebound viremia is what led to our identification that it was very early treatment that led to poor outcome. But here again, in 2015, even with our more modern regimen, this is a study done by Rossberger, by David Chapler's group at University of Minnesota. So these are adults now treated for 10 years. You would imagine, well, maybe if we treat longer, perhaps the kinetics of rebound would not be the same. And in fact, it's very disappointing, even with 10 years of continuous suppressive antiretroviral treatment. So a patient could be taking drugs for 10 years, and you go off treatment, and there's rebound in 2 weeks. In 2 weeks, you've lost a lot of time gained with respect to control. And so what are the implications of rebound viremia with ART discontinuation? I think what it clearly highlights is the efficacy of ART to potently inhibit HIV replication and prevent selection of antiretroviral drug resistance and rebound viremia, but really the incurable nature of HIV, which renders ART a lifelong endeavor. And so I want to go back now to the biological mechanism proposed behind the establishment of this latent reservoir for HIV in memory CD4 T cells. We've learned now since the discovery of this reservoir in 1997, really 18 months after the advent of ART, that these cells persist. You can detect them in the peripheral blood using special cell surface staining and cell sorting. And you can isolate them from infected individuals, put them in vitro culture system in a limiting dilution manner, and then at 14 to 21 days after stimulation and addition of lymphoblasts for virus expansion, you can readily detect infectious virus outgrowth in patients. We know now it's a heterogeneous pool of cells comprised of stem cell memory, central memory, transitional memory, and effector memory cells. So it's not a single cell type, it's a very heterogeneous pool of cells. Now, how are these cells generated? So this is the mechanism that was put forward by Bob O'Connor, who is my mentor when I started at Johns Hopkins in 1997. And his model was that this reservoir for HIV memory CD4 T cells is generated in the context of immunologic memory formation. So as I said earlier, the primary cell type that HIV replicates in is an activated CD4 T cell. When you're born, 90% of your CD4 T cells and CD8 T cells are naive. And so it actually takes up to 18 to 20 years to reach an adult complement of memory T cells, which reaches about 50% equally naive to memory. And so his hypothesis was that antigenic activation of these cells in the context of antigenic activation and formation of immunologic memory, where the cells transition from an effective CD4 T cells to memory T cells, is when these cells become infected. And so they return to a quiescent state, really to provide immunologic memory. So if you encounter this antigen again, you can have a rapid recall response to protect you from reinfection. So the central hypothesis here is that these cells are generated with immunologic formation, memory formation. These cells remain quiescent, but then at any time point can be stochastically reactivated to produce HIV. There's several other models that exist where these resting cells can actually directly be infected with HIV under permissive virus conditions, but I think the main mechanism that really follows the biology of the infection and what we know about persistence is really in the context of immunologic formation. Now I'm going to stop here and put a slide on the laboratory assays that are used, and it's very important to understand that there are multiple ways of detecting this reservoir in HIV-infected patients. The gold standard is really the quantitative viral outgrowth assay I described earlier, where these cells are purified from peripheral blood cells and then put in a culture system induced. And on average, there's about 1 per million CD4 positive T cells harboring this replication competent intact genome. Now, an easier measure is really a molecular measure where you can measure the total number of infected cells within a given individual by measuring the viral DNA in CD4 positive T cells or in total peripheral blood lymphocytes. So this is at the other end of the spectrum. So this is what's replication competent. This is what the total infected cell pool in an individual. And what you need to remember is that this measurement is about 300-fold times the induced replication competent virus. What that tells us is that most of the DNA that you measure in an infected person, so most of the cells carrying HIV DNA, have defective viral genomes. So they're not capable of rekindling Viremia. And so the field is kind of split. This is an easy molecular PCR assay to do versus this cumbersome, labor-intensive, requiring huge amounts of cells to characterize the induced replication competent reservoir. So we have several assays that are in between, looking at can you induce the proviral genomes to produce RNA? Can you also look at using sequencing to detect intact proviral genomes? And that's where these numbers really vary in terms of quantitatively per million cells what the size of the reservoir is. But the ones we'll focus on is total HIV DNA, which gives you the maximum estimate, and then the induced replication competent reservoir. So as I said earlier, the mean frequency of these cells is about 1 infectious unit per million, and these are the data summarizing the studies done in adults showing that this reservoir persists at 1 per million with 7 years of continuous therapy, and most recently by Dave Margoli's group with in 2015, up to 28 years of durable suppression, the frequency is about the same with no meaningful decay. Again, confirming the notion that these cells are long-lived or undergo homeostatic proliferation or proliferative renewal to maintain these cells. Now, in pediatrics, this is where we started our study. This was the first study to see did this reservoir exist in pediatric populations and were the size and the stability the same. And this is our first study, small study, first set of kids started combination therapy at Johns Hopkins. But these were children who were chronically infected, median age of 8 years of age, and we found the same stable pattern of persistence in chronically infected children. So the message is the same. The latent reservoir is comprised of a stable pool of infected cells. Now, the size is actually under question. The total body size is estimated to be about 1 million initially, but now with these newer assays showing this intact genome that are not induced with a single round in the quantitative outgrowth assay, this estimate has kind of increased now to maybe up to 100 million. So we still don't know the exact total body burden of this reservoir, but minimally it's about 1 million cells. They're present throughout the lymphoid system, making it very difficult to target these cells, forming the barrier to HIV cure. So what is the goal of HIV remission and cure therapeutics, and what's the rationale behind HIV cure therapeutics. So the main premise of cure therapeutics is to shrink this reservoir from 1 infectious unit per million. It's actually 3 logs lower. And I'll show you later the mathematical models that have been established to guide us in terms of what our clinical trial endpoint should be to consider someone being in remission or perhaps cure. Now, to get to the definitions of HIV cure, we think HIV cure is going to be a very, very rare event based on the durability of this reservoir and the size of this reservoir in patients with established HIV infection. So when we say cure, we mean that we've reached a state by some therapeutics where you've been able to completely eradicate all CD4 positive T cells bearing intact replication competent proviral genomes that could be induced. You can see that could be a very hard bar to reach. But HIV remission, I think we are having, where the hope comes is that with this research agenda, we're identifying on a case-by-case, really in the case series, case report stage of this therapeutic mission. But remission is really a state where an intervention has been done to lead to substantial reduction in the reservoir that would enable long-term virologic control when drugs are stopped. So in other words, when drugs are stopped, we don't see this rebound within 14 days. What the optimal time should be, 6 months or a year, needs to be defined. For our pediatric clinical trials, our endpoint is 48 weeks of remission for a very early treatment. Proportion of kids reaching sustained HIV remission, meaning control off drugs for 48 weeks following very early treatment. So these are the therapeutics that are under study. So as you can see, it's actually an emerging and growing field. It's very early antiretroviral treatment, which is the lowest hanging fruit for pediatrics because in terms of those with new infections, as I said, there's still 180,000 new infections in children worldwide because we know the timing of exposure. And so implementation of very early treatment strategies is very feasible in this setting. Latency reversing agent, so a way to reawaken the virus from its quiescent state with the hope that that will lead to virus production and cell death or elimination by immunotherapeutics in combination. Gene and cell-based therapies where CD4 T cells are undergoing target cell modification using zinc finger nucleases to modify the cell surface receptor, specifically CCR5, which is a co-receptor for virus entry. And individuals, about 1% of Caucasians are delta 32. They have a 32-base solution that renders them resistant to HIV that use that co-receptor. Targeting of inflammation, immune exhaustion, cellular proliferation, and then transplantation for malignancies to really shrink reservoirs. So you can see it's actually a very robust pipeline of proof of concept studies to achieve remission and cure. And yes, we do have examples of this making a difference. I think the Mississippi babies, what we identified, very early treatment. That child is treated within 30 hours of life that led to reduced reservoirs that we believe enabled remission in this infant. There's a group, European cohort, a Visconti cohort of adults treated during acute infection who've been off antiretroviral treatment for now over 12 years, 15 individuals. That would be considered remission. In those individuals, you can still detect HIV-infected cells. They've just been able to control the infection to prevent rebound of Viremia. And then more recently, there is a French adolescent perinatally infected adolescent who's in remission, 12 years of remission. A South African perinatally infected child at 9 years of age in remission. And then an adult patient in a PrEP trial in San Francisco who got treated very early, had a viral load of about 200 copies, went off treatment and had remission for about 8 months. And then the other extreme is really the Berlin patient who remained since 2009, the only patient cured of HIV. Very, very rare event, has not been replicated. There are many attempts to replicate the Berlin patient through examining HIV reservoir and rebound viremia in patients undergoing transplantation. The infamous 2 patients in Boston and a Minnesota patient have shown delayed rebound, but nowhere to the extent of 10 years at the Berlin patient, but confirming this notion that if we can reduce the reservoirs sufficiently, this could enable HIV remission where patients can go off antiretroviral treatment. And so to kind of pause a bit, this is really what we're aiming for, to go from our current state of treatment, lifelong ART, to a period where there's HIV remission. Obviously, you need to go through this period of remission before you can declare someone as being cured, where it is a lifetime of no antiretroviral treatment. So what are examples? As I mentioned earlier, the Mississippi baby is the best example of remission. And the Berlin patient is considered cured because he's now, I think, almost 11 years off antiretroviral treatment without resurfacing of plasma virus and no detectable HIV-infected cells. So quickly, the Berlin patient was reported in 2009 as having sustained undetectable plasma viral loads of 20 months off ART. This was the case that spiraled the thinking towards thinking of remission and cure for HIV. A single case that drove this whole field from going from conventional antiretroviral drugs that target active virus replication to a state where we can now begin to target reservoirs or creative cells. And he has remained off antiretroviral treatment. He does take PrEP for prevention of HIV infection. And his curative regimen, as you see here, is very, very extensive. Immune system ablation chemotherapy. He had acute myeloid leukemia that warranted this extensive treatment strategy. But importantly, his physician in Germany specifically looked for cells that are known to be resistant to HIV that use the CCR5 co-receptor, this delta 32 base pair deletion. So he was transplanted with HIV-resistant cells in addition to immune ablation. So we've learned many lessons from this single case, is that HIV is curable, but the measures to achieve this state is quite drastic with immune ablation to eradicate HIV reservoirs. But importantly, the major dilemma in this field is to be able to identify a state of remission or cure, you have to take patients off antiretroviral treatment. And so there are huge ethical considerations around doing this when so much time is invested in telling patients taking medications every day. And then when they're enrolled in the trial, we say, well, we have to take you off treatment. And that's the major bottleneck to research at this point, is we have no biomarker that's predictive of HIV remission and cure. And so just to briefly summarize, this is about the hype and the hope. There were 2 transplantations in Boston, allogeneic hematopoietic stem cell transplant, so recurrent Hodgkin lymphoma, and myelodysplastic syndrome. So the point of showing this is that it's not that the field is transplanting HIV-infected patients to achieve eradication and cure. It's an opportunistic approach in patients who require transplantation to look at the effects of the transplant on HIV reservoirs and rebound dynamics. And what you see in the first patient is that it took 84 days, so not 14 days, for rebound to occur in a patient with really a naive immune system to HIV. And in this patient, 210 days before rebound occurred, unannounced. Even though these patients had no detectable infected cells in the circulation, while being off antiretroviral treatment, they would still rebound. And this is the sobering part of the field, is that you can go without rebound viremia within 14 days, have no detectable circulating cells using our crudest measure, DNA, which tells you the maximum amount of cells you can have infected within a person, irrespective of whether it's defective or not, but yet there was rebound viremia. And you could see how this could provide a lot of hope, right? You're waiting, and every month you're checking, and there's no virus. When can you declare that someone's actually cured or really, cured? So this ends up being stages of remission. And, what the field has to decide upon is what's a reasonable period of remission to make this acceptable to take patients off treatment. If you talk to HIV-infected patients, they will take 1 week off treatment. Anything to not have to take meds every day and reminded every day of their HIV infection status. So the transplant cases, I think, really reinforced in HIV-infected adults that reaching low amount of infected cells enabled cure in the one case, and in the other 2 cases, afforded remission for several weeks beyond the 14 days. So at the time of the case of the Mississippi baby, so this is 2013, it's 4 years after the report of the Berlin patient, but it's when the cure agenda got activated in adult population. And So I think our mindset was really, we were in the frame of mind of developing a cure agenda for pediatrics. So, part of our mission is to not have children left behind with these new therapeutics, as has been done in the past with conventional antiretroviral therapy. And so I'm not sure if we were presented in this case in an era where cure was not being discussed, we would really identify this case. But nevertheless, it's the question for us as HIV consultants from Dr. Hannah Gay, who's a pediatrician, who started this child on combination antiretroviral prophylaxis, really with high-risk mom was infected, they received antiretroviral drugs and AZT 3cc nevirapine was started at 30 hours of age. Infection was documented by 7 days of age by having 2 different HIV-positive tests, and this child was continued on treatment for 18 months before being lost to follow-up for 5 months. So returned to 23 months, and that follow-up had been off antiretroviral drugs, had no detectable RNA in the blood, and in addition, tested negative by HIV DNA clinical assay and had no detectable HIV antibodies. So the question was, should this child be restarted on antiretroviral treatment? So first we had to convince ourselves of was this child really infected? And this is the viral load plot. This child had frequent viral load monitoring in the first 21 days of life, showing the classic biphasic decay in plasma viral load that's seen. So this, in our mind, confirmed that this really was an infected child. But what was different is that off antiretroviral treatment, there was no virus rebound within 14 days. In fact, she'd gone 5 months. So we decided to investigate what led to this, and it was starting the 3-drug regimen at 30 hours. We concluded that led to this outcome. So she was serially followed every month with viral load testing, and unannounced during this period of being off drugs, we looked for circulating infected cells, didn't detect any, looked for a reservoir, culturing 60 million resting cells, didn't detect any virus, no plasma viremia. In addition, she had absolutely no HIV-specific antibodies, no HIV-specific cytotoxic T cells to say these could mediate HIV control, and she had no protective alleles associated with long-term or elite control of HIV infection. So from this case, we concluded that this was really a case of HIV remission. On routine visits, completely asymptomatic, she represented on viral load. She had viral load of 16,000 copies and had rebound viremia. So what have we learned from this case? I think this case really demonstrated that lack of detection of HIV in the circulation did not signify cure in an infected person, but that very early ART reduced the reservoir size sufficiently to afford remission. And so this brings me to the mathematical models that's guiding our clinical trials, developed by Elson Hill and Bob Solcano, to try to figure out how many log reduction do you need in a given individual to minimize stochastic reactivation of those cells to rekindle viremia. And you could see in the Mississippi baby, the estimate was that she had about a 2.5 log reduction from that one infectious unit per million. In the Berlin patient, it's expected to be about 6 log reduction, and the Boston patient somewhere between 1.5 log reduction. So we're using these cases to kind of assemble some of our clinical trial endpoints for patients to determine HIV remission and cure. Now, from the pediatric lens, obviously very early antiretroviral treatment is the lowest hanging fruit for pediatrics. We know when the kids are exposed to HIV, so we can do early rapid diagnostics and start treatment early. In fact, in our clinical trials, we're starting treatment empirically in high-risk infants and then scaling back if they're not infected. These are, a major push by Dr. Fauci at the NIH is that cure approaches need to be safe, feasible, and scalable. And certainly, very early treatment and early treatment is safe, feasible, and scalable globally for pediatric HIV infection. Now, I want to get back to some of the science. We spent many years studying the dynamics of the latent reservoir in pediatric HIV infection. And what we found actually is in the first 2 years of life, the reservoir dynamics mimics that of adults. The size is large, it's inducible, it decays by 2 logs. But to our surprise, in the rejuvenation of a cure remission agenda and interest in reservoirs, we started to do long-term follow-up studies on some of our adolescents that were treated at 2 to 3 months. My pointer went out, but treated at 2 to 3 months of age, and then for up to 20 years. And what you see is, what's different from adults, you see that there's a decreasing in the amount of these infected cells in the circulation to as low as 10 copies. So they're already reaching the 1 to 2 log reduction with early long-term suppressive ART. a major limitation of this, and something that we're working on, is whether this effect is actually due to lymphoid expansion. Your lymphoid system expands through young adulthood, so maybe the number of cells is still the same, but there's an associational effect. But the unique hallmark here is the virus is completely clonal, it's not diverse, and these patients have no HIV-specific immune response. So it's a really great landscape for immunotherapeutic intervention. So what does our landscape look like? We actually do have several clinical trials in the field enrolling pediatric patients towards HIV remission cure. But most of it, actually all of it, currently is focused on very early treatment and early treatment in combination immunotherapeutics, broadly neutralizing antibodies, which I'll get to next. And so the main trial that's being done as part of the IMPACT network is T1115. This has enrolled 440 mother-infant cares, 48 clinical trial sites in 13 countries with 54 infected infants who are going through this very early treatment and the step 3 for ART cessation to look for viral rebound for those reaching a biomarker of no detectable cells in the circulation and being HIV negative. I want to switch quickly to latency reversal. So this is the main crux for patients with chronic infection in established reservoirs. The main goal now is to reawaken the virus from latency. And there are many agents that are being studied. The most studied are histone deacetylase inhibitors, which unravels the chromatin, allowing the virus to express itself. TLR7 agonists, certain cytokines such as IL-15. As you can see, the SMAC mimetics are being studied in non-human primates. So there are many shock and kill approaches that are under study to reawaken HIV from latency to lead to infected cell elimination. Now, the hype and the hope here is that the studies on reversal of HIV latency have been disappointing to some degree, in that what you see on these 3 panels or 3 slides in adults of 3 different histone deacetylase inhibitors, vorinostat, panabinostat, or romidepsin. And what you see is the blips show that these agents actually can reactivate HIV from latency as measured by cell-associated HIV RNA expression, but unfortunately it does not decrease the size of the reservoir. And this has led to studies now in trying to combine latency reversal agents with immunotherapeutics. And the main immunotherapeutic that's under study now is the field of broadly neutralizing antibodies. And I'm going to go through very quickly this field. These are highly potent broadly neutralizing antibodies. They're actually identified in HIV-infected persons, HIV-infected adults, about 2 to 3 years after infection. A subset of individuals develop these really broadly neutralizing antibodies, meaning it can neutralize many diverse, like over 120 strains of HIV. These patients don't control their own HIV, but they develop these antibodies. So these now there are multiple antibodies that are now available. The advantage of the broadly neutralizing antibodies, they're antiviral, they're long-acting, the half-life is about 14 days, but they can now extend up to several months. It's given subcutaneously or intravenously, and they have low toxicity profile. There are 4 classes that are in development, and what you see by pink, blue, and green are just showing the multiple parts of the HIV envelope that can be targeted by these broadly neutralizing antibodies. Now, how do they work? They work actually in several ways. These are really antivirals. They neutralize cell-free virus. But in addition, they have immune potentiating effects. The immune complex can present themselves to antigen-presenting cells and then trigger B and T cell responses. And they also can mediate ADCC effects. So in addition to their antiviral effects being long-acting, and hopefully we'll get to a point where these can be administered every 6 months, et cetera. They're being engineered that way to be used that way, that with this neutralization effect plus immunotherapeutic effect, immune modulatory effects, we could achieve a state of immunologic control in the context of low reservoir or with latency reversal. So we've known that studies done by Rebecca Lynch has shown for the first in-human study with DRT01, which is a CD4 binding antibody. This is the antibody that we're currently using in our trials, in our very early treatment trials in infants across the globe. These are antivirals. But what's an important consideration, up to 25% of individuals have pre-existing resistance to these broadly neutralizing antibodies. So it limits its use in that setting. And as you see here, there's transient reduction in plasma viral load, but then quick rebound viremia. So like antivirals, monotherapy leads to rapid selection of resistant variants. With these broadly neutralizing antibodies, monotherapy leads to early selection of drug resistance, and in some individuals, there's pre-existing resistance even without using these antibodies. Likewise, there's a second CD4 binding antibody, 3BNC117. Again, these definitely showing antiviral effects in adults. Infusions given every 3 weeks can sustain viremia for a certain period of time, clearly showing promise with respect to alternate approaches to suppress virus replication. Now, the field went on to look, can we give these broadly neutralizing antibodies to patients who are suppressed to see if we can delay virus rebound? And this is the first study of VRC01 in 2 different trials, the NIH and an ACTV trial, showing there was modest delay in virus rebound, as you see on the x-axis, weeks since discontinuation of ART and plasma viremia, but no substantial delay in rebound viremia with these administration. And that was in patients in chronic infection. Now, in the adult studies looking at acute infections, in these patients treated, this is a Thai study, treated during acute PBIG 1 to 3 infection with lower reservoirs. Similarly, repeated infusion of these broadly neutralizing antibodies. What's shown in red is the placebo group. The placebo group had a faster return of virus, and what in black are the study participants who got the VRC01. So there's a slight delay, about 10 weeks or so, with one individual going up to 42 weeks, but not substantial enough to warrant taking this forward solely as a strategy towards remission and cure. Now, what's very exciting is recently in the past month, there's been a report from Michelle Nussensweig's group here showing when you combine these antibodies, so shown in blue is a combination of 3BNC117, which is a CD4 antibody, and 101074, which rebinding antibody. When it was combined with infusions, what we're seeing now is delayed rebound with a median of 21 weeks in those who had sensitive reservoirs. So again, in the study, 2 out of 11 patients had pre-existing resistance to this combination antibody. But I think this provides hope that using these antibodies in combination could lead to sustained control of a virus reservoir. Again, this can be given intravenously. They're being engineered to be given every 3 to 6 months, so a much more palatable approach to antiviral control. And then I'll end with the therapeutic vaccine. Obviously, CD8-mediated control is critical for control of viremia. This is a study done by Dr. Fauci's group, DNA vaccine. What's seen on the left is a vaccine group and a placebo group on the right, but showing that using a therapeutic vaccine aimed towards T-cell responses rather than antibody neutralizing responses, there was no difference in the kinetic rebound. So I want to end with there is hope. There are about 93 interventional clinical trials being conducted in 26 countries around the world towards HIV remission and cure. Our pediatric agenda is heavily based within sub-Saharan Africa, where the burden of infection lies. We're building our portfolio with respect to therapeutic vaccines and in addition to use of broadly neutralizing antibodies. To kind of give you a snapshot of some of these are all proof of concept trials using vaccines or HIT-Stack inhibitors in combination with broadly neutralizing antibodies. Again, small sample sizes, but in the proof of concept stages. And just to say that we've embarked on combining these broadly neutralizing antibodies in the early phases of treatment when patients are still viremic, because if indeed these can serve as immunogens by binding autologous virus, then perhaps we can generate HIV-specific immune responses early in the course of treatment. So the hype comes, every year there's a case of remission. In 2013, there was a Mississippi baby, and 2013 Wisconsin cohorts were reported. In 2016, so these sorts of cases sustained or enthusiasm for the field, heavily weighted towards pediatrics, which suggests to me that in pediatrics we may have a greater shot at replicating our cases. So this is an 18-year-old who's had 12 years of sustained remission, certainly meaningful time frame of remission, and then the South African child, 9 years, actually now 10 years, post early treatment for 40 weeks, just time-limited treatment for 40 weeks, and then remission. We need to understand why these individuals, what are the host genetic factors, the viral factors that also contribute to this state of remission. So this is sort of our timeline. There was initial hope for cure in 1996 when ART was very effective at suppressing virus replication, but was quickly dampened in 1997 with the discovery of the viral reservoir, but reawakened, rekindled, really re-energized with the Berlin patient who is a great spokesman for this field. And then we have this cluster of cases or case series of patients experiencing remission that keeps us grounded. But the challenge of this research is we have no predictive biomarkers. You see in the transplant patients, there's no detectable circulating cells, yet they rebounded. In the Mississippi baby, no detectable immune responses, circulating cells, yet she rebounded. And so the challenge is for all of these interventions, patients have to go off antiretroviral treatment to be able to assess the effects of these therapeutic regimens, which is really an incredible task to ask patients to do. But in general, there's a commitment from study participants to really try to move the field forward. So I'll say the hope, this new research agenda shifts our treatment paradigm. I think changes us from status quo, take lifelong therapy, to really thinking, being visionary and hopeful towards being able to get to a place where patients don't need a lifetime of antiretroviral treatment. And it's important to remember the numbers, 36.9 million people living with HIV, 1.8 million children. So we're often asked the rationale for HIV remission cure strategies. It's really important, again, to emphasize it eliminates lifelong treatment, reduces stigma, eliminates toxicity, and there's a huge economic and logistic burden of delivering ART to people worldwide. I'll acknowledge our impact cure committee members who've been very active and the vision behind our clinical trials and the workhorses behind our clinical trials, and then many of the independently funded investigators involved in the cure agenda in Europe, in Thailand, in South Africa. And then I must acknowledge the people in my lab who do this work tirelessly with grace and passion. Listed in this slide, including Adeline Quay, who just joined your group here. Obviously, Hannah Gay and Catherine Zuriaga. Hannah Gay really recognized this as an unusual case, deserves all the credit for this. The funding agencies, Natella started with, the funding that I've received, but these were really critical funding to keep a pediatric agenda, pediatric reservoir agenda on the roadmap to get us to this place to talk about HIV cure in patients. And so with that, I'll stop and thank you for your attention.
Okay. I want to thank you, David, for the state-of-art review on a very complex and exciting topic. And we still have a few minutes of questions if anybody has some. Okay.
I really just so remarkable. Congratulations on that long body of work and from relating it so clearly. Could you comment briefly on genomic manipulation? There's recent quite startling reports out of China with CRISPR-Cas9 approaches to manipulating embryos to be HIV resistant is terrifying, but striking conceptually. Is there a role for that in adults or young children to actually reprogram cell populations to render them HIV resistant?
Yeah. So there. So first, I'll say I'm not sure we need to do it at the embryonic level. We have ways to prevent HIV infection, and the goal should be prevention, not genetic manipulation for resistance. But actually, I didn't. There were so many slides that I ended up taking out the slide on the gene editing. So zinc finger nucleases have been studied to edit the CCR5 and make a delta 32 deletion, and those cells are expanded ex vivo and then reinfused into patients. There was one study done out of UPenn using those reinfused genetically modified CD4 cells, CCR5 delta 32, and in fact the rebound Viremia pattern was not much delayed with those cells except for one patient, and in that patient, that person was heterozygous with CCR5 delta 32. So there are studies underway, even looking at cord blood cells, how to manipulate those one of the Martin Delaney collaboratories in Seattle is specifically looking at cord blood cells and perhaps transplantation with those cells towards generating an individual with resistance, cells resistant to HIV. In our own impact network, we have a cord blood transplantation study that's underway. It's in patients who had cancer requiring transplantation for that reason, in whom we've transplanted with CCR5 delta 32 cord blood cells. So we had 2 adults enrolled in that study. Unfortunately, one passed away at 1 year post-transplant, but our second study participant is actually doing very well, is engrafted with CCR5 delta 32 cord blood cells 1 year post-transplant, and so we're very excited to see. So there are many groups in the field trying to figure, even with CRISPR-Cas9, how to modify these cells to make them resistant to HIV. Thank you for that question and for the comment.
It was a great talk. Can you just update me a little bit about what the data is on the brain being a reservoir for latency and with HIV?
So you could say I completely avoided. I did mention it. I think the brain is very challenging to study, right? I mean, because it's just hard to access. The spinal fluid the spinal fluid mirrors what happens in the peripheral blood in terms of viral load. And a proportion of patients have a phenomenon what's called viral escape, meaning that the peripheral blood is undetectable to less than 20, but if you do a spinal tap, you can detect free virus in the CSF. But what's unclear, those are also associated with self-trafficking T cells. So it's unclear whether the source of the virus is actually from resident brain cells or from trafficking cells that then produce virus. So the way it's being addressed now, there's certain imaging modalities that are underway looking for neuroinflammation. The best way is really we need a tag to be able to tag virus. So maybe if we can have an antibody that's tagged with a molecular probe that traffics to the brain, then perhaps that's the way we can really define the CNS as a reservoir. The other approach, actually, there's a fantastic study in San Francisco, the GIFT study, in which HIV-infected patients at the end of their lives actually donate their brains, their bodies, for autopsies to do these extensive battery of tests. And I think through that study, we'll really be able to define the different anatomic reservoirs. In animal models, it's shown especially in the infant model, the virus gets into the brain very, very quickly. But what was remarkable with a broadly neutralizing antibody combination, the study was done by Nancy Haywood at Oregon Science. Within 24 hours, they were actually able to eliminate virus infection from the brain. So I think we need better studies to define the brain. Certainly, it's easy to access the latent reservoir. We have to get rid of that. It's a large reservoir. It contributes to viremia, but more and more studies are showing the viral sequences that are coming back are not exactly what we see in the reservoir. So places like the brain and other anatomic sites really need to be considered. And that's the next step. It's how do you begin to approach getting invasive procedures in patients to be able to define reservoirs. I know in the Berlin patient, he did have a brain biopsy, and there was but that was post-transplantation. Question?
It doesn't mimic like when you're first infected where you have huge amounts of virus. When you have this rebound, and is that because you guys are catching these people quickly and then putting them back on drugs, or do we think that it doesn't behave that way? Do you understand my question?
Yeah, no, that's a great question. Actually, I can't explain it, but most people rebound to their set point. Okay. So you're right. During acute infection, we have kids 30 million copies per ml. We calculate the total body burden. But then most people come down, right? So adults within 3 to 6 months, they reach a set point. In kids, it actually takes 2 to 5 years to reach that set point. So how we don't really perturb that set point if we treat them early. So in the case of the Mississippi baby, you can see her viral load was low, with 16,000, and she rebounded at 19,000. So most patients actually rebound at their set point, which makes me think there's some founder cell that's persisting, that's contributing to that. Because when you think about what contributes to that, it has to be how much virus the actual cell can produce and how much it can replicate in target cells. And somehow that's an individual value. You know, each person has their own viral load. You don't see, whenever you see two identical viral loads, you know it's a sample mixed up. It's just, thank you for that question. Well, thank you, everyone. Thank you, Nutella.
Just one more time, Debbie. Thank you very much, because the very high-end science is so nice to explain. Thank you very much.